Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
My colleagues and I would like to thank LE&RN for this opportunity to talk about this very important topic of the relationship between pregnancy and lymphedema. There will be time at the end for questions and answers, so please use the Q&A box to enter any questions you may have during the presentation. The three of us began this exploration into the relationship between lymphedema and pregnancy a little over a year ago, thanks to the introduction from a colleague. This project really even surprised us with how intertwined the two conditions really are and how little this is being addressed. So we're so excited to be sharing all of this with you today. We want to thank the corporate sponsors of LE&RN to make this webinar possible. And of course, since we are discussing medical aspects, we do have a disclaimer that you should speak to your healthcare professionals prior to beginning any form of treatment. So who are we? I am Dr. Shelley DiCecco. I am on faculty at a medical school here in the United States, and I am also a lymphedema instructor. Joining me later will be Ria Lewis-Strange, who is a physiotherapist from Wales, and Diana Mesre, that is also a lymphedema specialist in Wales. And we also want to do a special thanks to a recent graduate of mine, Dr. Catherine Downing, who assisted us in the research. We've divided our webinar into 4 sections. We'll first go over the physiology and pathology, then we'll talk about a focus group, some case studies, and then get into some treatment options for pregnancy with lymphedema. We completed a systematic literature review to investigate the relationship, and so it was quite long and heavy, so I'm going to try to break it down in a much easier aspect for everyone today. So there's several major systems in the body, and our initial research question was which systems are actually involved with pregnancy? How are they related? What is the impact? And what we found is that all of these systems are actually impacted by pregnancy. I know this flowchart's a little busy, so I'm going to try to show the big picture on the slide. As most of us know, hormones and the endocrine glands play a very vital role in pregnancy. So this slide has taken 3 of those pathways, adipose tissue or fat tissue, the pituitary gland, and the hypothalamus, to go through briefly how, when things go awry with any of these 3 pathways, we end up with swelling in the tissues. If you start up at the top with adipose, which is technically an endocrine gland, adipose releases hormones and other chemicals, and this can cause an increase in adipose itself, but also in cholesterol and leakiness of vessels. And it also encourages the laydown of fibrotic tissue. So it can lead to more swelling and fibrosis in the tissues. The pituitary gland releases your LH and FSH hormones that are going to impact your ovaries and adrenal glands, which lead to more releasing of your progesterone, estrogen, and other hormones. These will also impact the adipose route. They impact your sodium levels, which can lead to water retention. And then they also impact your arteries and vessels more. They cause nitric oxide to be activated and cause vasodilation. When vasodilation occurs in the tissues, you end up with more fluid entering into that tissue, so you end up again with more fluid in the tissues. The last pathway we're going to look at is the hypothalamus. This one's going to interact on the nervous system. So specifically your your sympathetic nervous system, excuse me. And what that's going to do is actually impact your vascular system also. So it can cause vasoconstriction and alterations with dilation, which can lead to an increase in edema and swelling into the tissues. So what we found, if there's any imbalance in any of these pathways, you can lead to lymphatic dysfunction. When we looked more closely at the hormones, this drawing is not to scale, it's just to show you the general relationship between the hormones and pregnancy. that you do have a spike in 3 of your main hormones, that the estrogen, progesterone, and HCG all will increase. The estrogen goes up about 50 to 100 times, and the progesterone increases about 10 to 20 times over what a woman would typically have during menstrual cycles. Each of these hormones have their own reactions that they're going to cause. Your estrogen is going to impact your kidneys, so this will impact your sodium and water retention levels. It's also going to impact onto the pituitary, like we just saw, and it encourages you to have more of an anti-diuretic effect. So most people know of diuretics when they have swelling due to heart conditions to help get rid of fluid. Estrogen's impact during pregnancy actually causes you to hold on to the fluid more. Progesterone, along with estrogen, can also, as we saw in the last slide, increase nitric oxide, which is going to lead to vasodilation, which will lead to an increase in leaky vessels or fluid in the tissues. And then your HCG also has been found at high levels to cause the vessels to leak more into the tissues. Of note is that progesterone and the HCG at high levels have a significant correlation to the risk of preeclampsia for the pregnant individual. So again, if any of these hormones are out of balance, you're going to have some lymphatic dysfunction or overload starting to be seen into the tissues. We realize hormones are not the only thing that changes during pregnancy, that I think all of us know that there are some biomechanical or postural changes that are going to occur. That obviously with the enlarging fetus, that the abdomen is going to start to expand. When this happens, it causes the center of gravity or our balance component to shift forward. In order for our bodies to compensate for this, you'll start to see an increase in curvature at your neck and your low back or lumbar and cervical spines. Your pelvis starts to tilt forward. Your shoulders start to turn in and round forward. Your knees start to hyperextend or over straightened. Your feet, you will notice, start to flatten and spread out. And all of these changes cause either shortened, tightened muscles or stretched out, weakened muscles. We took those changes and then we overlaid it to the lymphatic system. That if you look at the areas where we have the most changes, we also have key components to your lymphatic system. That it is common for women to have what we call TMJ retrusion, which is where your jaw kind of goes backwards versus protruding forward. And that's going to impact the submandibular nodes under your jaw. The curvature in your spine or the cervical lordosis can actually put more pressure or compression onto your cervical lymph nodes. The internal rotation or the curving in of your shoulders and pulling them kind of forward can actually compress into your axillary nodes. The curvature in your low back or lumbar lordosis can put more pressure onto your pelvic nodes. The fetus growing can actually put pressure and compress the thoracic duct, which is your largest lymphatic vessel in the middle of your body, your inferior vena cava, and your iliac veins. And then it also will put pressure onto the pelvic nodes. And then even the knee extension is going to put compression forces onto your popliteal nodes behind your knee. There are also other causes that we found with swelling for pregnancy. And with all of these, it could be where the individual had them before they became pregnant or they developed these conditions during pregnancy. They all could lead to edema. So diabetes is a big one. That when you have diabetes, it causes your vessels to become more leaky. So diabetes in general is known to cause inflammation into the tissues. And with pregnancy, this increases even more so because of the hormones with it. If you have venous insufficiency or varicose veins or any vein issue, that your veins can't carry fluid back out of your extremities, especially your legs as well. And so you're going to have more fluid remaining in the tissues. Activity level. If someone was more active prior to pregnancy and during pregnancy, they typically have less swelling than the individuals that are less active. Pregnancy in general, as we saw from the very busy slide earlier on, actually impacts cholesterol levels because of the estrogen and progesterone. So it's already naturally going up. cholesterol, one of its adverse reactions is through the vessel wall, it actually causes vessels also to become more leaky. So there's more fluid entering the tissues. And there was research showing that high LDL levels of cholesterol is associated with preeclampsia, preterm delivery, and gestational diabetes. That all individuals, when they become pregnant, typically gain weight. We need the calories and stuff to support the other life. So we have more adipose tissue coming on. And studies have found, due to the chemicals released from adipose tissue, that the higher level of adipose tissues the individual had before or during pregnancy is going to cause more leakiness into the tissues. And then abnormal sympathetic and parasympathetic nervous systems, that as you're messing with or changing your vasculature, whether it's dilated or constricted, it can cause problems with swelling. And your sympathetic nervous system and parasympathetic were also associated with preeclampsia. We then started looking at what areas are typically likely to swell for individuals that are pregnant. And if you overlay all the graphs and charts we've kind of shown you, you'll see they all start to kind of mesh over each other, that if we overlaid them, they'd all have spots at all the same areas roughly. So 1 through 8 is done in the frequency of swelling. So most people have feet and ankle swelling, and then leg swelling, which those are going to be impacted by your inguinal nodes and your popliteal nodes. Next, we're going into hands and fingers are the most common. And 1, 2, and 3 are mostly due to gravity too, that those are the ones that hang down the most. So it's harder for the vessels to work to get the fluid out. 4th likely to swell is around the face and the neck, then the genital region, then the abdomen, then the arms, and then the last typically are the least likely to swell is going to be the upper trunk. And this was looking at individuals without true lymphatic dysfunction. So when you add in dysfunctions in those areas, those numbers can shift around and change based off of where the individual had lymphatic dysfunction prior to pregnancy. While lymphatic dysfunction itself is typically not life-threatening, we do need to mention that there are several dangerous lookalikes that need to be cleared prior to starting any therapy. These include preeclampsia, HELP, which is hemolysis, elevated liver enzyme, and low platelet syndrome, so HELP is much easier to say. Your deep vein thrombosis and congestive heart failure, those are the big 4 that really need to be monitored closely. Then other causes that need to be addressed by medical community is your infections, organ diseases, gestational diabetes, and malnutrition. So all swelling must be cleared by a physician before you may start any form of treatment for that swelling to make sure that none of these dangerous lookalikes are involved. So now I'm honored to turn the presentation over to Ria.
Hello, thank you very much for having me. My name's Ria. I'm a physio working in NHS Wales. I'm here to talk about a focus group that we ran within our network, looking at the views and perceptions of NHS Wales lymphedema clinicians on lymphedema and pregnancy. Our aims are, as you can see, we wanted to look at the range of, if any, experience clinicians had working within Lymphedema Network Wales had with working with pregnant people with lymphedema. And we wanted to determine the education needs for those clinicians when working with this particular patient group, and identify those aspects that therapists found to be most challenging when working with pregnant patients with lymphedema. So we're based in Wales. We are a comparatively small country. We have a population of about 3.3 million people spread across 7 health boards that cover the whole of the country. We also have a national lymphedema team that I work for, which covers all of Wales. All residents of Wales who are at risk of or diagnosed with lymphedema can have access to local assessment, advice and treatment to support them to manage their condition. Regardless of where they live, they'll be able to access a lymphedema clinician, and they can be referred into the service by any qualified healthcare professional. NHS Wales uses the principles of prudent healthcare to ensure that we are managing our patients efficiently and effectively within the most relevant and recent research to maximise the benefits that the patients will have. but also there is a need for us to work within budgetary constraints, and all interventions must be evidence-based and equally accessible across the country. Our participants, our focus group took place during a session of our national leadership programme. There were 8 participants in total, with 2 focus group facilitators, myself and Diana. All of the participants were working in Wales, and we had participants from 6 of the 7 health boards that cover the country. So we had most of the country covered with those participants. They were from physiotherapy and nursing backgrounds. Those professions form the majority of clinicians working with NHS Wales Lymphedema services, and all clinicians were senior and had at least 3 years of experience working within lymphedema. Our focus group methodology. So we wanted to ensure that it was a very non-judgmental environment. All members of the focus group consented to participation in the focus group, and for the focus group to be recorded to allow for transcription purposes. They were given verbal information relating to the content of the focus group about a month prior to it running, and they all consented to participate. We set out ground rules to ensure that there was an equal opportunity for all members to contribute, that confidentiality of conversation was maintained, and to ensure that it was non-judgmental. It was conducted in a quiet room, there were no interruptions. And we did use some prompts to guide the conversation back to topic should it veer off on a tangent, but we're very cautious about introducing investigator bias into the conversation, which was quite a challenge, while ensuring that the conversation remained on topic. As I mentioned, the conversation was recorded and was then transcribed. It was quite an organic conversation. It flowed very well, and it was very interesting to hear the varied viewpoints and experiences of staff from across Wales. The data was analysed using thematic analysis. So 2 experienced lymphedema clinicians analysed the conversations and drew conclusions from those conversations. And then it was sense checked by the clinical director of Lymphoedema Network Wales. We drew the key themes down into 4 main categories, as you can see there. So professional roles and responsibilities, lack of knowledge and education needs, funding and capacity, because that is quite a pertinent topic within NHS Wales at the moment, and patient experiences as reported by therapists. One of the big things that came out was the limited experience reported by therapists of treating pregnant people with lymphedema. In the first quarter of 2024, so we work with financial years that run from April, so from April to June this year, Welsh Lymphedema Services treated about 4,000 female patients, or patients who identify as female. 322 of those were aged between 15 and 45, which we sort of took to be the majority of childbearing age. Obviously, there might be outliers to that. So about 7% of the female patients seen between April and June would be within that childbearing age. However, unfortunately, our data doesn't collect whether any of those patients were pregnant at the time that we saw them. Of interest, the mean age of female patients within NHS Wales, within the lymphedema services, is around 68, so it is an older population. And the Office for National Statistics, which is the data gathering body in the UK, reports that approximately 600,000 pregnant people were in Wales in 2022 from a population of 3.3 million. However, our lymphedema clinicians are reporting that they see very few of those. So is there an unmet need out there? Are there patients out there who are struggling with their edema that we aren't being made aware of? Clinicians raise concerns regarding garment selection, treatment selection, and contraindications because of their quite limited experience of this particular area. And also they raised concerns about what was normal versus pathological edema, and when to escalate these concerns to. And I think these concerns were linked to lack of exposure to pregnant people with lymphedema. We have quite low numbers of patients being referred in, so is there an unmet need? And this is causing quite a lot of anxiety amongst clinicians within Network Wales, because obviously they're not being exposed to those patients. Education needs ties very much into the lack of knowledge, so they highlighted there needs to be educated around improved knowledge of causes of normal physiological edema in pregnancy, and also improved knowledge of pathological causes of edema, as Shelley was discussing. What relevant healthcare professionals would need to be involved if there were concerns. What was the ceiling of concern? When should clinicians be raising concerns about pregnancy and edema, and who should they escalate those to? They wanted to develop knowledge of management techniques because they were quite concerned about the sort of lack of perceived knowledge around that area. And it's worth noting the majority of lymphedema clinicians in Wales are adult trained nurses. There's a few paediatric trained nurses, and there are physiotherapists, but we have no midwives working within Lymphedema Network Wales, and we have no specific training for pregnancy. Roles and responsibilities, so this related to professional roles and responsibilities. There was a feeling that midwives, obstetric consultants, and general practitioners could have a more proactive role in managing normal pregnancy-related edema. Several members of the focus group who had themselves been pregnant prior to this focus group reported having experienced edema in pregnancy, and they were told by their midwives that it was just a normal thing to happen, it will settle, and they felt there was no real understanding or concern as to how that edema was affecting them on a day-to-day basis, and they didn't really report anything being suggested to help manage it. They felt that the wider MDT, so MDT is the multidisciplinary team, it's what we call our group of health professionals that work with a particular patient. There was a feeling that they could have a more significant role in identifying those patients who were in need of edema management and take a more proactive role in referring on to the appropriate services like lymphedema clinicians if specialist input was needed. It was felt that there was a greater knowledge of needed among the wider sort of health community of the possible contributions of a lymphedema therapist could make within this particular patient group. But again, there were concerns raised about, you know, with increased knowledge comes increased referral rates of patients, and there were concerns raised about how local services would accommodate increased numbers of patients being referred in. We also struggle, we have limited sort of cross-professional documentation. We are a very paper-based service still, and it can make it quite difficult to ascertain full medical and obstetric histories if you don't have full access to a patient's medical notes. So paper-based notes were making things more challenging, which was a concern that was raised. Funding and capacity, which is a very hot topic in the NHS. Obviously, we run a very different health model to the majority of the world. There were challenges reported by therapists when it came to working with people, pregnant people with lymphedema, and accessing education. We have some issues with study leave at the moment, so we're finding it difficult to access funding to attend courses or for time away from clinic to attend either formalised education or peer-to-peer support in different clinical areas because of the pressures of clinical loads at the moment. And that makes it quite difficult to expand your knowledge base in this area, compounded by the low numbers of patients who are seen in practice. There was a concern that if there was quite a significant increase in the number of pregnant patients being referred in with lymphedema, that there would be insufficient resources available to be able to work with those patients. And we aren't really seeing these patients unless they're already known to a lymphedema service. There are patients who are, you know, already on our caseload who are pregnant or become pregnant while they're with us. Those are the majority of the cases that we were finding. But if there's a lot of pregnant people out there and there's quite a reported incidence of edema, where are those patients? They're not being referred into our services. So is there a missed need? Patient experiences. So as Danny will discuss a bit later, the effects of pregnancy can be quite significant. The effects of edema in pregnancy can be quite significant. And if no one's addressing it, it can lead to some potentially quite detrimental situations. Therapists reported from their own personal experiences the impact that edema in pregnancy had on them and the lack of support that they felt they were offered by their health team with regards to management of these symptoms. So just in conclusion, it really became clear that more education was needed for professionals working with lymphedema specific to pregnancy-related edema and the treatment choices available. We need to establish a robust evidence base to support treatment choices because this feeds into the NHS ethos of prudent healthcare. It's got to be evidence-based and it's got to be value for money. We need quite a proactive education programme to involve the healthcare professionals who work with pregnant people to identify those people who are struggling with edema, to ensure that they are having input at the most appropriate time, in the most appropriate environment, with the most appropriate interventions, again, in line with evidence-based and prudent healthcare. The focus group was a very small focus group. It was targeted specifically to a group of clinicians working within lymphedema. But the themes that were coming out of it made it clear that really we need to sort of be casting our net wider now. We need to look at a larger population to establish the knowledge base of lymphedema in pregnancy, the knowledge base of other clinicians working with these people, and expanding the sort of the net to catch more professionals, really. So on that note, I'm going to pass you on to Danny or Diana.
Thank you very much, Ria. Yeah, my name is Diana Meres. I'm known as Danny. I'm a clinical lead for the Lymphedema service in Cardiff and Wales University Health Board in the capital city of Wales. And today I'm going to be presenting our patient case studies. So just before we start, all information is confidential and the patients have given us consent to share this information for the purpose of the research. So to plan the case series and latter research, I chose to use the Plan, Do, Study, Act, or PDSA cycle, which provides a framework for developing, testing, and implementing changes. As this was ultimately a new clinical improvement project and we were starting on a small scale, the PDSA cycle approach seemed quite well suited to our study. And today I'll be presenting our first PDSA cycle. So why have we chosen to use case studies? Well, the patient's perspective is now becoming an important aspect in the reorganization of any healthcare service, and patient stories form an integral part of improving both physical and psychological care. Pregnant women are often underrepresented in research, as Shelley has said, and research in pregnancy and lymphedema is very limited, as well as there being any management guidelines in this area. So the case studies can be illustrative because they can describe unfamiliar situations and help us understand the patient's experiences, but also they're exploratory and can help us guide and develop theories and plan for the large-scale projects. So these are personal accounts and they can give us real-life context and background to the challenges our patients have faced. And through this, we wanted to reflect on our own practice and develop solutions to ensure that we're delivering high-quality patient care with good patient outcomes. So the aim of our first PDSA cycle was to gain an understanding of the healthcare experience of the storytellers. So how did pregnancy affect lymphedema? What were the challenges? What was good? What was bad? And what would have made the experience more positive for them? We especially wanted to know about the patients' experiences with treatments, their healthcare service, and what daily life was like living with this chronic condition. An individual story may not be in itself representative of all patient experiences, but each patient's story and experience of our care within our services is valid, and we need to listen and learn from them. And collectively, we wanted to use the stories to help us build a picture of what it's like as a pregnant patient with lymphedema and how we can improve on the service we provide them. So as Ria has mentioned, in Wales, the average age of our female patients with lymphedema is 68. So managing patients with pregnancy and lymphedema is not routine. So we decided to select patients from Wales and the USA to represent different etiologies, and their cases were chosen by the researchers, which we are aware that makes our first research cycle vulnerable to selection bias. I will be discussing 3 unique cases of lymphatic dysfunction in pregnancy, one involving a patient with primary lymphedema, one with breast cancer related lymphedema, and a patient with no prior history of lymphedema, but who developed it in her second pregnancy. These will hopefully demonstrate the challenges these patients encounter during their pregnancies and the types of patients and symptoms a clinician may encounter in their everyday practice. So our first patient is patient A, who developed right-sided breast cancer in 1997. She was treated with a mastectomy, excision of 12 axillary lymph nodes. She had chemotherapy, and then she went on to have reconstructive breast surgery. She developed mild lymphedema to her right arm about a year post-surgery, and this was managed well with compression garments and regular MRD. She had 2 pregnancies, and during both pregnancies, she experienced swelling to her affected arm. She reports that in both of them, the swelling increased progressively starting in the second trimester, but it significantly worsened in the third trimesters. So in order to try and manage her increased swelling, she continued to see her lymphedema therapist regularly, wearing compression garments, and then later changed to using a compression wrap system, but also increased her MLD treatments to weekly. Her edema did return to baseline postpartum, but it's interesting to note that she reports that the swelling took longer and it was worse in her second pregnancy compared to her first. And it's also interesting to note that in patient A's story, she didn't complain of any lower limb swelling, and she actually focused more on the swelling to her arm. Our second patient is patient B, is a 24-year-old who has a rare genetic abnormality, which resulted in her developing lymphedema to her left arm, trunk, and leg from childhood. Her past medical history includes recurrent cellulitis and severe lymphedema, which she self-manages with multi-layering of a huge range of class 2 flat knit and circular knit garments. So this patient is particularly self-aware of her lymphedema, and she individualizes her compression on a daily basis. And this continued through her pregnancy, especially in the third trimester, when she really noticed an increase in her swelling. Despite her primary lymphedema affecting both her left upper and lower limb, she actually reported that it was her legs that were heavier and harder to manage. And she managed her edema by layering of her garments as usual, but said that she didn't actually do anything novel or very different from her normal routine. She continued taking prophylactic antibiotics throughout her pregnancy to reduce her risk of cellulitis, and she describes that need to be extra vigilant with her daily preventative measures like skincare. And although this was her first pregnancy, patient B opted to have a C-section in order to minimize any genital swelling or trauma. But for her, it was actually post-operatively that patient B really noticed an increase in her pain and her swelling to her legs. So she increased the layering of her compression garments and also used compression wraps. But interestingly, she particularly found kinesio taping to her foot really helpful in reducing her swelling and keeping her tissues nice and soft. 18 months later, patient B is back in her pre-pregnancy garments, but her baseline edema is higher than what it was prior to getting pregnant. So patient C is our patient with secondary lymphedema. We need to declare that actually this patient is a qualified lymphedema therapist with a history of sarcoidosis and recurrent miscarriages. At 38 years old, she was given progesterone 400 milligrams BD to help prevent miscarriage, and she was able to successfully carry her first baby to full term. Early in her third trimester, she experienced swelling to her hands and legs, and also reports the development of very visible prominent varicose veins, in particular to her right leg. The veins and the swelling both progressively worsened until she delivered the baby. She wore class 1 compression tights and felt that at the time her swelling was actually really well managed. But a few months postnatally, the swelling in the varicose veins had completely resolved. She became pregnant again 9 months later, also receiving progesterone treatment. And this time, the patient describes the pregnancy was a lot more challenging than her first. She complained of more varicose veins, increased weight, pelvic girdle pain that resulted in reduced mobility and the need to use crutches. And in her third trimester, the patient suddenly reported a massive increase in the swelling to her legs, but also, again, mostly to her right leg. And despite multi-layering of her compression garments and using wraps, she found the swelling was really difficult for her to manage. So her legs continued to worsen until her third trimester, as well as increased shortness of breath. And following an urgent echo, she was diagnosed with peripartum cardiomyopathy or congestive heart failure at about 34 weeks. She went on to have a C-section, but this patient then developed a wound infection postoperatively, and that resulted in a cellulitis to her abdomen and also her right leg, which required emergency admission into hospital and IV antibiotics. She similarly reported that her swelling after her second pregnancy was worse and required bandaging as well as multi-layering flat knits and circular knit compression garments and using a compression wrap. But she was able to reduce her swelling back down to baseline, but it took about 2 months. And she now has mild lymphedema that affects her right leg. So the stories covered a broad range of experiences, and they developed, quite meaningful insights and addressed all of our aims that we were aiming to achieve. Although they all had different causes of lymphedema and they lived in different countries, there were many collaborating themes that may have in fact led to changes in our practice and to improve patient care for this group of patients. So we'll have a quick look at those now. So all of our patients experienced increased swelling, and this was particularly noticed to be within the third trimester. There was a necessity for these women to have support from the lymphedema clinicians, but also shared decision-making between them and their obstetric teams to ensure their safety. The compression garments needed altering in order to control their unstable edema, and all reported the need to use multi-layering of their compression garments and wraps. Cellulitis was a particular challenge for 2 of our patients. This was especially a concern to patient B, who was high risk and reported that needs to be extra vigilant to ensure her and her baby's safety from infection. But also patient C, who was admitted into hospital postoperatively with cellulitis. And I think it's worth saying that increased skin vulnerability, surgery, and immune system changes in pregnant women mean that women with lymphedema are probably more susceptible to cellulitis. And this highlights how beneficial monitoring and adjusting the treatment plans were to these patients as their pregnancies progressed, and also postnatally. And possibly one of the most important issues that was raised by all the patients, and perhaps actually overlooked by us when we first started the study, was the inability of all of our patients to be able to breastfeed, either due to their lymphedema or because of their underlying comorbidities. Both of our patients that had multiple pregnancies reported that the pregnancy-related swelling was worse during their second pregnancies compared to the first. They both reported that the increase in their swelling seemed to start earlier in the second pregnancy and also took longer to return to baseline postnatally. But there were in fact some underlying causes, and Shelley's already kind of covered these as well. So both reported an increase in weight gain, which we know can exacerbate lymphedema by putting additional pressure on the lymphatics. But patient C had a very complicated pregnancy with pelvic girdle pain that affected her posture and her mobility. And later in her pregnancy, she developed cardiomyopathy and then cellulitis, all of which are likely to have had an impact on her swelling and to her development of lymphedema now. So I know Shelley has discussed this slide, but it's worth covering again because clinicians should be questioning, when does swelling fall into the normal category of pregnancy-related swelling? And when does swelling become abnormal, indicating an underlying condition that requires treatment? Ria mentioned the clinicians in our focus group recognized that there could be pathological causes of edema in pregnancy, but expressed uncertainty as to how to diagnose this. And patient C's case highlights that actually there is a real need for education to aid early recognition of potential complications related to the pregnancy, so that timely and appropriate treatments can be commenced, where actually you're addressing the root cause rather than just the symptoms. I didn't feel that we could actually talk about pregnancy and not mention varicose veins, because they are very commonly reported in pregnancy and a cause of lower lymphedema. So patient C did complain of them in both of her pregnancies, as do 40% of pregnant women. In most pregnancies, they're caused by a combination of increased blood volume, compression of the inferior vena cava and the iliac veins by the growing uterus, but there's also actually the hormonal element. So relaxin and progesterone both relax the smooth muscle and veins and decrease valvular function. And usually we see varicose veins developing in the second trimester, which then continue to worsen until delivery. So these pregnancy-related varicose veins usually resolve postpartum when the hormonal levels drop. But in some patients that may have existing risk factors for venous insufficiency prior to getting pregnancy, such as obesity, long-term contraceptive use, lymphedema, now known as Lymphagia syndrome in the UK, and a family history of venous insufficiency, just to name a few. And additionally, multiple pregnancies are reported to increase the progression of venous insufficiency. So it's reasonable to expect in some women previously silent or existent venous insufficiency and lymphedema can be exacerbated when pregnant. And it can be a big problem for them. The varicose veins can be really painful, and venous insufficiency is a progressive condition that can advance into chronic venous insufficiency. So it warrants early diagnosis and treatment. And conservative treatment with compression garments is usually recommended during pregnancy for varicose veins. But if the varicose veins of the legs and the vulva persist for longer than 3 months postnatally, then patients probably should be referred on then to their vascular and lymphedema services for assessment and treatment. It's also worth mentioning here that pregnant women are procoagulant, and that in the case of unilateral edema, DVT should be excluded. And patient C reports that despite the swelling affecting her right leg mainly, she was never investigated for a DVT. So what therapies worked? Well, more research is really needed to evaluate what treatment modalities are most effective to manage edema in pregnancy. All patients in this case series wore multi-layering of compression garments and used compression wrap systems, highlighting the need for high levels of compression to control their edema during and post-pregnancy. Increased manual lymphatic drainage and multi-layering compression bandaging were also reported to be very therapeutic. And Shelley is actually going to go into this in a few more details, so I will stop at this point. So knowledge of healthcare professionals significantly impacted on our patients' experience and outcomes. Patient C, who was not under a lymphedema service or a vascular service, found that she had very little support from her obstetric team. And despite her midwives and consultants noting the swelling to her leg several times, it was often ignored. And she was frequently told it will get better postpartum, which it did with her first pregnancy, but it has since persisted with her second pregnancy with no follow-ups. As a lymphedema therapist, she was able to self-manage, but expressed concern that other women who may be in a similar situation as her without any support or intervention need that support. Patient A and B also reported that they had very good support from their during their pregnancies from their lymphedema teams, and found their expertise in setting expectations and preempting how their lymphedema would change was important for their well-being. And this resulted in effective treatment plans by anticipating the changes and reducing the risk for potential risks and complications. One of the advantages of the patient stories is they reveal hidden emotions that are lost through clinical data. So please read through some of the quotes, because these were all embedded within these stories, and there was a wealth of emotions, in particular the immense joy and excitement that comes with welcoming a new life, but also they express their fears and frustrations, offering us a profound insight into their lived experiences. They uncovered feelings of vulnerability, loneliness, and the fear of how their lymphedema was going to change, what treatment was safe, what treatment wasn't safe for their baby, and fear of becoming unwell, and that strong need for a support network. Across all three stories, there were feelings of failure that their swelling had worsened, and also sadness at not being able to breastfeed. And two stories discuss quite deeply about how they felt overwhelmed with the demands of looking after a new baby, and also the guilt at not fully engaging with their lymphedema care plans. There was also acceptance and great resilience, and quotes like, "Lymphedema has taught me about the challenges my body faces, but pregnancy has shown me the beauty of my physiology." And these stories provided a really deep understanding of the emotional and psychological impact of lymphedema and pregnancy, and the huge importance of us addressing their well-being alongside their physical health. All right, so to finish our first PDSA cycle, we concluded that the understanding of, or the impact of lymphedema in pregnancy is crucial for providing the most appropriate care and management and ensuring the well-being of these patients and their developing babies. Early education, preemptive treatment planning can help mitigate the worsening of their symptoms, but ultimately their lymphedema shouldn't be a burden to their pregnancy. I'd like to thank the patients who provided us with their journeys and through pregnancy and lymphedema, and we gained so much insight into their challenges, satisfaction, and their recommended areas for our service improvement. And I'm now going to hand you over to Shelley, who will finalize our presentation on current evidence-based practice on treating lymphedema in pregnancy.
When completing our review of the literature, we also researched common lymphedema interventions for guidelines during pregnancy. We took what we knew about the pathophysiology of both lymphedema and pregnancy to complete our list. First, a disclaimer that clinicians out there, please make sure you are completing a thorough evaluation of all systems and confirm with the OB/GYN prior to initiating treatment that the individual is safe. And for pregnant individuals, please make sure you do speak to your OBGYN before beginning any treatment for swelling. As with any medical intervention, there are always precautions and contraindications. I'm not going to read these out to you, but as you read through them, you can see that any bleeding, pain, signs of labor, signs of distress, or changes in vitals are concerns for the treatment, and the patient needs to be placed on hold until the OBGYN can clear the pregnant individual and the fetus. Blood pressure and heart rate vitals should also be monitored regularly with pregnant individuals. So I'm going to go through a few of our most common interventions that we use in therapy. So physical activity. It can help with improving cardiovascular health, weight management, and musculoskeletal changes. It does need to be slow paced and low to moderate intensity, so around a 40 to 60% of previous levels, and build up from there. Your manual lymphatic drainage, it does reduce fluid in the tissues, it helps with the fibrosis, and it can also, as any form of manual therapy, reduce stress, anxiety, and pain. Though the therapists do need to be cautious, there should be no deep abdominal techniques. We should be careful of the position we place the patients in and monitor vitals, especially due to shifting the fluid and the nervous system responses to manual therapy. Aquatics is very similar to physical activity with the benefit added of weight reduction. So it takes the growing weight of the fetus off the joints. So the patients can often do a little bit more exercising. Keys with this is the patient does need to stay hydrated. We do not absorb the fluid from the pool. We also should not go to any form of pain or fatigue. And we do need to be cautious with any individual that has breathing or incontinence issues. Compression, which is a big portion of what we do for lymphedema treatment. I'm going to have all of them on one slide. So whether we're looking at bandages, garments, or pumps, the bandages are used mostly to reduce the fluid and tissue changes that occur with lymphatic dysfunction. Garments are typically used more for prevention or maintenance, and then compression pumps can be used as an adjunct treatment for both the reductive and maintenance phases. There is actually no research on any of these three on appropriate compression levels to use over the abdomen. Most of your over-the-counter compression garments or pantyhose have at most 20 millimeters of mercury over the abdomen. So we recommend using caution with any application of compression bandages or garments over the abdomen, and to not go above 20 until more research can be concluded. With compression pumps, one should avoid any compression over the abdomen or even the trunk of upper extremity involvement, and one should reduce the time and compression level for any extremity use, especially the lower extremities with pregnant individuals. With all forms of compression, one should always monitor vitals and other symptoms. Elastic taping can be used, especially for like postural support and to reduce these pain and edema levels by lifting up the dermis. Just watch out for tape irritations or allergies. Please be careful to avoid taping over any large superficial vessels such as the femoral or the carotids. This is because, remember, as we discussed earlier, these vessels have become more leaky due to the estrogen and progesterone in the areas and other changes, and they're more likely to have injuries with tape over them where you could actually rupture a vessel. Vibration is frequently used in lymphedema treatment to reduce edema and tissue changes. However, you need to make sure you avoid whole body vibration and vibration over the abdomen or low back with pregnant individuals. You still can use vibration by like a wand type device over the extremities. Since vibration can lower your sympathetic response, you do need to make sure you're monitoring heart rate and blood pressure. Ice and heat can be used to reduce pain, anxiety, and some swelling or edema. It does reduce the extent of a vascular reaction and reduces harm to the fetus with both of these. So you need to make sure that you are not using it over the abdomen or low back. You also do not need to be using ice or heat on any part of the body for more than 20 minutes at a time, because your body will then go through what we call a whole body vascular response. They're trying to overcome what you're doing to that one area, and you can end up with full body vasodilation or a hunting response by using ice or heat for longer than 20 minutes. So we found all this great information, much more than we could even include in this webinar. So what are our next steps? So to go back to Diana's PDSA cycle on the ACT phase, we have just launched a lymphedema practitioner survey. We are working on getting larger focus groups in other countries. We want to make sure we're going to include the voice of the patient, so we do have a patient survey coming up. We want to use this information we gather for these three to develop more edema and pregnancy assessment tools, to try to develop maternity vascular and lymphedema pathways for clinicians, and to develop clinical and patient educational materials. This new international survey for all healthcare practitioners is available in multiple languages, and what we're trying to find out is what is the actual knowledge that practitioners have. What do they feel they need? How do they feel they need it? What are they seeing in the clinic? What are the populations coming in? So we do highly encourage all of you that are practitioners to please take the survey and encourage your fellow colleagues. All updates on this will be on lymphed.com's website. In the near future, we will be launching the patient survey. So whether you are currently pregnant or have been pregnant in the past and had any form of swelling during pregnancy or postpartum, if you would like to be informed when this survey is going to go live, we ask that you email Diana. She's keeping a list so that as soon as it's live, we can send out a post. And it'll be updated on the pregnancy page of lymphed.com. So from all of us, I would like to thank you. Here is our contact information if you have any questions or concerns. Also, if you fill out the healthcare survey as practitioners, you are given a handout of the interventions we discussed and what is safe and what is not, and how is it actually impacting the patient. So at this point, we will open it up for questions. So if my other two colleagues will turn their cameras back on, we can try to go through as many of these as possible in the time we have left. So the first question is, would multiple birth pregnancies increase chances of developing lymphedema? I think all of us could, did we stop sharing? Oh, let's stop sharing so they can see better. There we go. Yes, that it's not to say that everyone that has multiple pregnancies will definitely get lymphatic dysfunctions, but with anything you felt during pregnancy, whether it was back pain or anything else, that usually there is a progression of your symptoms from your first pregnancy with additional pregnancies. So is it going to be worse? Possibly. Could it be something that eventually it leads, as in case number 3, where it went away after the first one, but it has not gone away after the second one? We don't have enough information on that, and that's what we're hoping the rest of our research kind of helps us find out for the 3 of us and all of you too. The lecture will be recorded and placed up on LE&RN's website. Diana, do you know if patients usually have a resolution of symptoms after childbirth? And I know you said that your patient with a history of breast cancer did, but should we assume this is true for lower extremity lymphedema also?
I think, I think it depends really on the etiology, what's causing the lymphedema. Most certainly our patient with primary lymphedema reported that although she managed to reduce her lymphedema back down, it was still higher than her original baseline. And again, there's contributing factors to that, like increased weight, like in patient C, the development of varicose veins. So I think it really depends on, so many contributing factors, whether or not the lymphedema completely resolves post-pregnancy.
Another one for you, Diana, is what were the comorbidities of why the individuals could not breastfeed?
I think the patient A, obviously, because she'd had breast cancer and she'd also had lots of reconstructive surgery. Patient B with primary lymphedema actually had lymphedema to her breast tissue, so didn't feel that she was able to. And patient C did breastfeed with her first baby, but because she had cardiomyopathy with her second baby, she was on a very strict fluid balance. So she really struggled to actually kind of produce milk to be able to sustain breastfeeding.
Ria, is the lack of support that the patients and the clinicians are seeing, is that due to insurance? Is it due to knowledge? What would you say are the big reasons there's lack of support on both sides?
Obviously, we're Wales based. We don't have the issues with insurance coverage like you would have in the US because we have a universal healthcare system. So if you need it, you get it. But I think it probably is a lack of knowledge of the input that lymphedema clinicians can provide with this group that is a barrier to patients being referred in. One, if there's, as Danny was mentioning, the case studies that she had, a lot of those were already patients who were under a lymphedema therapist, under a lymphedema clinic already prior to getting pregnant. So there was no barrier to treatment for those patients. But I think if they've never been diagnosed with lymphedema prior to being pregnant, I think there is probably a very big lack of knowledge amongst obstetrics or OBGYNs in America or general practitioners to know, oh, actually, this is what it could be, and I need to refer that patient on. So I think for Wales, it's definitely not the insurance coverage side of things, but I do think it probably is a lack of knowledge.
I can say from the US with the patients I've had in my past that I've never had an issue where insurance didn't agree to pay for the CDT or complete decongestive therapy phase. It was more the physicians understanding what we were trying to do to refer patients or to agree to the treatment plan because they didn't know how the movement of fluid would impact the patient. So I haven't had where they've refused my actual treatment. Now, obviously, garments is a whole nother issue with insurances, but they never said the patient could not come to therapy for me. Diana, did any of the cases have thyroid issues? Was one of the questions.
It's not something that got brought up, actually. No, it wasn't something that was mentioned in the stories, but something I'm definitely going to be thinking about for the next one.
It'll probably be one of our questions. Yeah. Tip sheets, do we have those available? If you go to lymphed.com, that I do believe I put them up there. If not, you can email one of us and we can get you the handout, or the clinicians. I'm going to make you take the survey to get the handout. But all we have right now is what we found on the interventions. As we move through the progress, if you keep going back to Lymphed, we'll keep updating what we found, what we are giving out, that we'll obviously be trying to get as much information out there as possible. But as with anything, it does take time to go through the research process. What's your experience with OBGYN's knowledge of lymphedema and assisting in diagnosing? I think it has to do with kind of this. I think it's worse than what you deal with regular lymphedema, that we already struggle, and I think every country, with physicians knowing what we would like them to know about lymphedema, like how to recognize it, what are treatments, what are long-term complications. When you add in the specialty of pregnancy, you kind of double down on that I think the lack of knowledge, and because it's not been researched, that it's not that I don't think the doctors don't want to know about it, is that the types of articles we had to go into and books that we were into, neurochemistry and all these other books that aren't typically looked at by healthcare practitioners, our practitioners don't know where to go to get information, and they don't have it to know what to do about it. That even a physician recently just said in a Facebook post that there's no connection. Well, based off the research we went through, which again, we're only showing you a portion of, there is a significant correlation through multiple pathways between the two aspects. We don't have any cases currently on twin births, but that will be something we will be looking at in the survey. Because pregnancy seems to be the trigger for lipedema, a focus on this population could be added. Yes, lipedema will be in the patient aspect, and it was included, I do believe, in the clinicians to a point. I'm curious about we went through breastfeeding. Lymphedema after my third C-section, I was told that I have lymphedema tarda. Does this sound accurate based on your research? Diana, you want to try that one?
I suppose like lymphedema tarda means that you've developed lymphedema sort of, later on in adulthood. Most certainly, like we've discussed with some of the case studies, pregnancy can sometimes be a trigger for lymphedema. And again, it depends on, what's causing your lymphedema, because there are so many causes for lymphedema, like venous insufficiency, like trauma, surgery. Most certainly having 3 C-sections can cause a lot of scar tissue in the abdomen, and that can cause lymphedema. So it depends really where your lymphedema is, what underlying comorbidities you have, for us to kind of figure out what's causing your swelling. But it's not unreasonable. No.
Do we advise women to stay physically fit during pregnancy? Yes, that there is plenty of research out there that shows inactivity because of the muscle pump and also adipose severely adversely affect your lymphatic system. So whether you're pregnant or not, the more fit you can stay, the better your lymphatic system will function. Ria, what's the probability of the lymphedema being passed to the baby from the mother's swelling?
Oh, well, I mean, it depends. Is there a genetic component? That's an impossible question to answer, unfortunately. Obviously, there are some conditions that have strong genetic components, at which point you would need to be under a genetic counselor to go through that. But there's no evidence really to suggest that if a patient's developed lymphedema in pregnancy, that they would pass that on to their child.
Yes. And the last one we have currently in the questions box is, do you recommend a normal delivery or a C-section? That is something that's beyond the scope of this right now, that C-section decisions are based on a lot of information. So we don't have enough information behind us to kind of help guide patients on what to select. But I think by having a open and frank communication with your doctor and having your therapist involved, I have written letters to doctors on some of my patients for other things besides just lymphedema, on why they need to either have or not have a C-section based off of other things I'm seeing, and then having a conversation about it. But it's unfortunately, with everything that goes into pregnancy, there's not a one choice answer. So I think we all greatly appreciate all of you that joined us today and those that will watch this later in the future for giving up your time for this. And we hope you will continue to help us with our research, because this is something that we've only just hit the tip of the iceberg, and there's so much more we need to know and get out there to everyone. So please help us in the future. Thanks again to L&RN for having us and having all of these wonderful webinars to increase the knowledge we all have now on lymphedema over the last several years. So thank you.